Senior Carvalho, and everyone else. Can I ask you to come back, please, for the discussion? We'll make it very quick. Does anyone have a question? May I ask you to ask quick questions, short questions? This way, there also some paragraphs.
I will make a very short question about concept of mental health. I know we are all maybe academics here from our scope what mental health is, what it should be. Sometimes because we are questioning, we do induce already some bias. Have worked years in sub-Saharan countries where we tried also to do counseling and mature the heads for mental health, because healing a broken bone is easier than mental not well-being, whatever. I'm not talking about psychiatric diseases. How does it fit in then with migrant people who not very use the concept as we see mental health, and of course when they come here, and of course they have gone through a long way, whatever it was on the road, and then suddenly they can be labeled with, I have a mental health problem, and so I can't feel good because I am a migrant, and it's normal that I am not good. Eh? So how does it fit in your research? Do you look also at data from there? How does it go with mental health perceptions or conceptions? Because I'm really sometimes malaise with our concepts on mental health and other concepts.
May I maybe summarize? Do you have specific description, an international description of what is depression, for example, or if what is a post-traumatic syndrome, that could be international and that you could put in the debate, maybe?
Thank you very much for this question. I tried to bring up this issue at the end. We have international classifications of diseases which include psychiatric disorders and which are validated across different settings. So, in principle, and the extent to which the prevalence of psychosis is almost the same in most parts of the world. The prevalence of other forms of disorders, I mentioned neurodevelopmental disorders. It will also be in studies that have been conducted, for instance, in Asia, in the Emirates, or in India. It's found to be 1%, like it is in Europe. So, for some disorders, there are really clear definitions which can probably be applied across the board. For psychological symptoms and the ways in which people express distress or their suffering, it's probably more difficult. And that's why I suggested that there should be more data, actually, and there should be more research trying to validate these types of questionnaires in different settings, and really trying to figure out. We sort of assume that people understand the questions in one particular way, but I think there's not enough data about this. What I can say about measures of distress, anxiety, different types of psychosocial symptoms is that generally what has been found is that especially among people who come from countries where there are fewer psychologists, psychiatrists, maybe the concepts of mental health are not so well known, is that essentially scales that actually measure people's physical symptoms, whether they have different sorts of pains, back pain, headaches, sleeping problems, and so on. Those are sort of universal symptoms of suffering and distress. And what we found in different studies is that those are the types of questions where people are most likely to actually report difficulties. But there's need for more research on that.
Thank you. Sir, you had a question?
So it was argued, and rightly so, that giving migrants access to preventive and primary health care saves in the long term. But exactly the same is true for the indigenous population. So it's not a migrant problem, it is oftentimes a political problem, because we ask politicians to invest in the short term to get benefit in the long term. In the long term, they'll not be in office anymore, so they're not interested in the long term. I'm generalizing. And so, I mean, this is the problem you describe is not a migrant problem, it is a general problem with healthcare. And so I don't think it has anything to do with migrants, to be honest with you.
Since you have the microphone, I have a question, because I don't think that was really a question, but I have a question for you. He's talking about politics, actually. So you have this study. Did you send it to politics around the countries you were talking about? And what was the reaction also? Because I think it could be related.
There were some conferences and there was a lot of information spread around on the study. We did not get any feedback from policies.
Okay.
But I saw that Dominic Zenner from IOM is here. Perhaps he has different experiences.
I don't see. Là-bas, monsieur qui c'est ça?
Can I just come back to the statement that was made? And I'm glad you did say that, because it's very true what you say. And I think one of the things that we have learned from looking at newcomers, migrants, is that they tell us a lot about other dispossessed people in our society. The elderly, the disabled, low socioeconomic people. We are learning a lot about those populations by looking at migrants. So I'm glad that you brought that up. It's very important.
I think it's about individualization of care on the one hand, but there is one big difference, and that is the legal entitlements. And I think this is something policy can change, or the policy action is needed. Yeah? So this makes a real difference.
Just the last question? Are you? I don't know. You? Sorry? You have the microphone, so just go ahead.
Yeah, sorry. So my question is to the two who carried out studies. How did you involve the populations you studied besides giving them questionnaires?
The population we studied was involved only via organizations. We did not contact people directly. In our economic study, for example, we addressed healthcare organizations who provide care for uninsured, for undocumented migrants, and so on and so on. It was a question of having the situation that migrants trust these people. They are in regular contact, they are talking with the social workers, and so on and so on. So we could ensure that we have no problem of having the fear that the study might not be anonymous. This is a very difficult to reach group of people for researchers, because there is always the threat that personal data will be reported to authorities, and so on and so on. So in this study we have not been in contact. In other studies we are working together with migrant associations, for example, or we are in contact with, we are directly addressing them, and also develop research questions together with migrant groups.
Okay.
But this was...
So, if I can just comment on that question. First of all, in both studies which I mentioned, there were pilot studies to test the questionnaires, so of course people were asked about their feedback regarding the questionnaires. And then in the Enfam study, the study of homeless families, actually, well, first of all, my colleague who coordinated the study once she realized how little healthcare access people had, actually made her self-referrals for many, many families, which was completely outside of the study. And I have to say this is something that we've actually discussed a lot because, of course, you know, people signed an informed consent, they answered a questionnaire, and in principle there is no individual benefit to participating in the study. I mean, I think she just sort of went beyond her research capacity just because she was so bewildered by the complete absence of access to healthcare, including for families which had very severe health problems. And I have to say that also the organization which is in charge of housing these families, I mean, finding them hotels and so on, has moved forward in trying to be a little bit more in touch with the families and offering preventive health services, you know. So there has been some benefit to the participants, if that was your question.
Thank you so much. I think we will close the discussion and go eat because lunch is waiting for us. And so it will be upstairs, same room as for the coffee break.